For our next session, I'd like to call upon the chairpersons, Dr. Yogesh Vashist. He is an associate professor at the Medias Klinikum from Burghausen, Germany, and Professor MC MISRA. Sir needs no introduction. Sir is a very senior figure. He has served as the director of AIIMS New Delhi, and we've been fortunate enough to have him as the vice chancellor of our university as well. So I invite them to kindly call upon our next speaker. Dr. MISRA is.
Good morning. Can you hear me?
Yes.
Yes. Please, Dr.
Good
Yogesh.
morning. Hello.
Yeah.
So, is Professor MISRA also online? I cannot see.
Dr. MISRA may not be able to join because he has another commitment at 1 p.m. So please carry on.
So, thank you for the invitation. And it's early morning, according to German time. It's snowing outside right now, 8 o'clock. That's why also excuse my appearance. I don't know Mr. Bansal personally, but I have been given this task to chair the session of SELSI consensus statements. From what I have read so far, these are statements that have been developed by after 3 consensus meetings for especially tailored.
I can introduce Dr. Bansal.
Yes. Dr. MISRA is there. Good.
So let me introduce Dr. Bansal. Is a professor of surgery. He is heading a surgical unit, which is surgical unit 4 currently at All India Institute of Medical Sciences, New Delhi. He is a very skillful kidney transplant surgeon and also minimal access surgeon, and also breast cancer. He deals with breast cancer extensively and all GI spectrum other than liver, portal hypertension, inflammatory bowel disease. He has done large number of pancreaticoduodenal resections for periampullary cancer. He has also done large number of benign bile duct strictures, and he has been involved in the organization and establishment of Society of Endoscopic Laparoscopic Surgeons of India, Indian Hernia Society, besides his other commitment with transplant societies. Also involved in International Endo-Hernia Society, which was initiated by Professor Reinhard Bittner from Stuttgart, Germany, where we were involved in guidelines on evidence-based guidelines on laparoendoscopic groin hernia. So he has been instrumental in structuring these guidelines for the prevention of common bile duct injury during laparoscopic cholecystectomy, which have been adopted by SELSI guidelines. So we invite Professor Bansal for telling us about these guidelines which are in vogue, which have been published in Indian Journal of Surgery. This was a lot of hard work done by a lot of people. So Dr. Bansal would tell about it. Professor Bansal.
So at the outset, I would like to thank Professor VK Kapoor for giving me this opportunity of spearheading this SELSI guidelines for safe cholecystectomy. Actually, it is he who had written the basic framework for these guidelines, and then SELSI as a society took it up, and we formed a consensus, and it was published as a consensus statement for safe cholecystectomy for prevention of bile duct injury by the Indian Journal of Surgery. So why do we need guidelines? We need laparoscopic cholecystectomy is one of the most common procedures. The risk of bile duct injury, even after so much technological and laparoscopic experience, is still higher than the open cholecystectomy, and the incidence has been variously reported in the literature. Although recently there are few publications where the incidence of bile duct injury has been reported to be very less, but still the bile duct injury does occur. And at the institute, both at PGI Chandigarh and at our institute, I think the experience has been that we still see more common bile duct injuries after open cholecystectomy than a laparoscopic cholecystectomy, although they are now almost 50-50. bile duct injury can lead on to dreaded complications, and so it was felt that there is a need of safe cholecystectomy program in India, and we must make an attempt to reduce the incidence of bile duct injury and to manage it timely and appropriately. When this task was taken up, there were no Indian guidelines. These Western societies like the SAGES and EAES do have their safe cholecystectomy guidelines, but in there are certain peculiar situations in India wherein we need our own guidelines. So it was felt that we need to make our own guidelines. Also, a SELSI consensus statement to guide a general surgeon with basic laparoscopic skills on how to perform a safe cholecystectomy was thought of. The process of consensus development included, as I said earlier, a draft guideline was prepared by Professor Kapoor at SGPJ Chandigarh. Then it was handed over to SELSI. These guidelines were circulated to all the SELSI experts for comment, and draft was divided and allocated in various headings to groups of people so that they can work on it individually. And the first consensus meet was held in 2016 at AIIMS New Delhi, wherein around 60 experts attended this meeting, and wherein these draft guidelines were presented by various experts, and the various points raised by these experts were discussed and further defined. The statements and the recommendations based on the literature were framed and graded according to the evidence-based guidelines. And a consensus meet was again held in 2017 in December, and these guidelines were finalized, and the changes were recirculated to the experts. And then once these guidelines were finalized, then they were presented in the annual meeting of SELSI held at Jaipur, where around 1,000 delegates participated, and these guidelines were deliberated upon again. And then these were circulated to 3,500 members of SELSI, and all the comments and the suggested changes were included in these guidelines. And these evidence-based guidelines were published in Indian Journal of Surgery. I would like to thank Dr. Sandeep Kumar, who is the chief editor of Indian Journal of Surgery, for being very helpful in the publication of these guidelines, because without his help, I don't think so these guidelines would have been published in the way they have been published. So this was published in 2 issues actually. So what do the guidelines contain? It contains a definition in the beginning of the centers, specialist centers, the specialist surgeons. The bile leak, how do you define it? The external biliary fistula, how do you define it? And the incidental cancer gallbladder also was defined in the beginning of these guidelines. Then the recommendations and the statements were based on 3 parts, basically: before cholecystectomy, during cholecystectomy, and after cholecystectomy. The indications of cholecystectomy were graded according to the literature, and the various grades of recommendations have been given in these guidelines. The preoperative workup was discussed among the experts, and a consensus was reached, and the various recommendations were then written in these guidelines. This is very important because in India the preoperative workup may not be very standard in majority of the places, so this was thought to be a very important part of these guidelines. Then the problem of difficult laparoscopic cholecystectomy was discussed, and then we found that the level of evidence, although was not very high for difficult cholecystectomy, so these predictors of difficult cholecystectomy were also labeled so that people in the private practice, general surgeons who do not have so much laparoscopic experience, they can refer these patients appropriately to centers where these patients can be managed, rather than taking up these patients on their own, so that the dreaded complication of bile duct injury can be avoided. Then various instruments which are required for cholecystectomy, laparoscopic cholecystectomy, were also discussed, and the preoperative preparation and their grades of evidence were also included. What was the consensus has been written in these guidelines. The standard 4-port laparoscopic cholecystectomy has been recommended, and the position depends on the preference of the surgeon, and then the pneumoperitoneum and the tilt of the patient and the position of the patient also has been described in these guidelines. The pneumoperitoneum, open versus closed, also the literature has been reviewed, and there is no difference as per the literature, and it's a grade A recommendation that either you can do an open or a closed method of pneumoperitoneum. The standard 4 ports have been described, and intra-abdominal pressure has been advised, and there was a consensus among the experts that direct trocar insertion without pneumoperitoneum is not recommended for anything. The operative steps have been described in detail so that the surgeons can follow these steps, and the various levels of evidence for these operative steps also have been graded according to what is available in the literature. The posterior dissection, the interior dissection, the role of Rovier's sulcus, and the critical view of safety also has been discussed. The evidence for critical view of safety has been, although very low, but it was a grade B recommendation that the critical view of safety should be demonstrated in all cholecystectomies wherever possible. There have been certain bailout strategies also has been described, and the literature has been, the evidence has been graded according to the various grades and the consensus of the experts. If the critical view of safety is not attained, then intraoperative cholangiogram, laparoscopic ultrasound, a fundus thrust approach, a subtotal cholecystectomy was a grade B recommendation. Although the literature does not come up to grade B recommendation, but still the experts felt that it is a safety mechanism which can be adopted in difficult situations, and conversion also has been graded. Then the clipping of the cystic duct and the cystic artery, the proper use of diathermy from the liver bed, and the gallbladder extraction. As was being discussed in the previous talk, we said that preferably in an endo bag. Endogenous endo bag can also be used, which is easily available in all the ORs. A blood bag can be used as the covering of that blood, IV set can be used as endo bag very easily. The stone and bile spillage also the literature has been graded, and drain placement has been graded as no use of drain as a routine, level 1A, grade A recommendation. The bile and stone spill complications also have been graded. And then the most important part is that during cholecystectomy, when do you suspect a bile leak? As we all know, and Dr. Kapoor has written a book on it also, Safe Cholecystectomy, which we launched a few 1 hour back during our SELSI meeting also, that if there is a bile leak from the porta or hepatoduodenal ligament, if the cystic duct stump retracts down to the duodenum, and if there is a third tubular structure in the Callets triangle, and the principles of safe cholecystectomy also have been discussed. The acute cholecystitis treatment, as well as the management, as well as the treatment for this has been recommended. The early laparoscopic cholecystectomy may be done safely within the first 7 days, which is a grade B recommendation, and it was also added that it should be done by surgeons experienced in lap cholecystectomy for acute cholecystitis. It should not be done by everybody. A person who has not done an acute laparoscopic cholecystectomy in acute cholecystitis should not be taking up this kind of a surgery. It should be referred to a specialist center. The management of concomitant gallstones and CPT stones also has been discussed, and various recommendations have been made. If you get bleeding during cholecystectomy, unexpected findings during cholecystectomy, bile during dissection in the Callets triangle, bleeding in the Callets triangle, bleeding in the gallbladder bed. So these all have been given in the algorithm form for the surgeons to follow. So if you get some unexpected findings, when to convert, when to refer, if you convert, then what needs to be done. If you don't convert, then what needs to be done has been given in an algorithm fashion. And the difficulties during cholecystectomy have also been discussed, and the evidence has been graded, and recommendations have been given for various problems. So if you see bile in the Callets triangle, so is there thick viscid bile depending upon the nature and the content of the bile? Various recommendations have been made that whether you can proceed, whether you need to call an expert, whether you need to refer these patients without doing anything. And the major recommendation which came out, as we all have been stressing, that it is if you see bile coming from the hepatoduodenal ligament, it is not a good idea to convert. The best is to put in a drain and refer the patient to a specialist center. Then various scenarios during the cholecystectomy also have been discussed. The bleeding also has been discussed. How to manage the bleeding has been given in an algorithm fashion, so that the surgeons can read it and they can practice this principle. If you have bleeding in the gallbladder, then one needs to convert in the gallbladder bed. Then one needs to convert if one cannot control the bleeding, and if you do not have so much of laparoscopic experience, or even actually the expertise is if not available. After finishing the cholecystectomy, as was being discussed in the previous talk also, it is always recommended to open the gallbladder, see the normal mucosa, and send the gallbladder for histopathological examination. And if you detect some unusual findings, then it is better to mark those specimens, send it for histopathology, and refer this patient to an appropriate center within the expected time framework. So after the cholecystectomy, if there are various scenarios, like if the drain was placed, if the drain was not placed, there is no bile leak or there is a bile leak. So it is given again in an algorithm manner that if the patient is not feeling well, not taking orally, there is a lot of nausea, vomiting, there is a lot of pain, what we call as unsettled abdomen, do not discharge these patients, keep these patients under observation, re-examine these patients, observe these patients, get them the ultrasound done, get a LFT done, and do whatever is appropriate. A re-laparoscopy earlier than later is the norm in these patients. These are the recommendations which have been made in these guidelines. So in case of if there is a drain and there is a bile stain return, then do not discharge the patient, get a LFT done, get a ultrasound done. If the ultrasound shows no findings, you can reevaluate. If the ultrasound shows a collection, then maybe needs a ultrasound guided pictal drainage or a CT scan, but may require a definitive surgery. And one should always keep in mind that a re-laparotomy may be indicated in these patients. If the drain output is decreasing, then one may continue to observe these patients. One may need an early MRCP to confirm that the CVD is visualized in its entire length. If the leak is from cystic duct, early ERCP and stenting has been recommended. And if you do not have facilities, refer the patient to an appropriate center. Then another scenario is that if there is no bile leak but the patient develops jaundice, then obviously it's a bile duct. The bile duct has been injured, whether it's a partial injury or a full injury, we don't know. So the appropriate management has been described in these guidelines. External biliary fistula management guidelines also have been described, and the algorithm has been given for the management of these patients. So the principles are that index of suspicion for bile duct should be high in any laparoscopic cholecystectomy or even open cholecystectomy. Threshold for investigations in the postoperative period to look for a bile duct injury should be low, and bile duct injury should be managed at a specialist center rather than any person managing the bile duct injury. Aim of management of an acute bile duct injury is to convert it into a controlled external biliary fistula by draining the bilioma or by draining the bile duct with an endoscopic stent. By draining the bilioma with the percutaneous drain or with the laparotomy, whatever way you feel is the right way. And early repair of an acute bile duct injury is not recommended. Delayed after 4 to 6 week repair of a biliary stricture performed by a specialist surgeon gives the best results. Then certain medical legal issues have been discussed, and common reasons for a medical legal problem have been detailed. And it has been mentioned that one should document operative findings, preferably with a video or even a still photograph of the intraoperative findings should always be followed. And adequate timely management and referral is the key to avoid medical legal issues. And in case there is a complication, one should not hesitate to communicate to the patient, to tell the truth to the patient. They will never go in for a case if you tell them what has happened, and give them appropriate management, refer them at the proper time. And as we always say, maybe it is a good idea for the surgeon where this bile duct injury has occurred to communicate directly with the specialist surgeon at a center near him, and maybe accompany this patient to the center so that this patient gets the treatment that he requires and he gets. And counseling of these patients is very important. And document these complications. Do not try to hide these complications. Majority of the medical legal cases occur because the surgeon has tried to hide these complications. If you document that there was a complication, then I don't think so there is any reason for any medical negligence case, because complications do occur and we all know that complications can occur. And it is always a good idea to refer the patient to a specialist center at an appropriate time. So to conclude, I would like to say that always have a high index of suspicion for bile duct injury. Follow steps of safe cholecystectomy to avoid bile duct injury. The threshold for investigations to look for a bile duct injury should be low. When I say this, I mean that don't think that you cannot cause a bile duct injury. Any surgeon, howsoever experienced he or she may be, can still cause a bile duct injury. So always suspect that you may have caused a bile duct injury. And bile duct injury should always be managed at a specialist center where this is being done regularly. Convert bile leak into a controlled external biliary fistula. Early repair of a bile duct injury is not recommended, and a delayed repair of a biliary stricture performed by a specialist center gives the best results. So the best strategy, as Dr. Kapoor likes to say, is prevent bile duct injury. Next is to avoid delay in diagnosis, and early recognition means a re-laparoscopy or a re-laparotomy. So early referral to a specialist center with repair in experienced hands at an appropriate time gives the best outcome. Thank you. Thank you so much. I hope I have stayed in the time limit.
Thank you, Professor Bansal. This was truly a
where the thinking, old thinking was that it is a result of abscess from anal gland or fissure.
Some video is playing, please stop.
so, Professor Bansal.
Yeah, Yogesh, please carry on.
Having a guideline is one thing, but implementation, and you also wrote that in your abstract in the both publications, that this is special meant for the private hospitals and solo practice, where you only have often one surgeon, I believe, and you have rural areas. I mean, I am living in Germany, but I know how the situation in India is. If you are outside of the major cities, how do you ensure that these people, surgeons follow these guidelines, or at least ensure a certain quality of standard?
So thank you so much, Dr. Yogesh, for asking that question. Actually, we could have published these guidelines in any of the journals, actually. So we thought that we would publish these guidelines in Indian Journal of Surgery, as Indian Journal of Surgery has a readership of around 20,000 surgeons in India. So that is the reason we published these guidelines, and we hope that these surgeons would read these guidelines. And I would be very happy to let you know that actually I keep on getting statistics of the readership of this article. Yes. And till now, I think more than 5,000 reading citations have been received by me for these two guidelines. So I hope that people read these guidelines and follow these guidelines, and bile duct injury can be prevented. This is just a hope that people do read it and do follow it.
If we have time, I would like to have two, three more questions or comments. Professor Bansal, I mean, what is your take on fluorescence imaging? Is it routinely available? Are you applying or propagating it to do it in a special situation like in a country like India?
Okay. So as far as ICG fluorescence this thing is concerned, at present, I think very few corporate hospitals and some big public hospitals have this facility. Even at All India Institute of Medical Sciences, we still do not have this facility. And I think for prevention of bile duct injury in a specialist center is not a problem. The prevention of bile duct injury is a problem in the rural setup, in the solo surgeon setup. And there, I don't think the ICG fluorescence is going to play a major role in the coming years, because the technology is expensive. It is going to take, I think, more than 10 years to percolate it down to that level. So that is why we have not specifically talked about it in the guidelines. And personally, I have used it in very few cases, and I don't feel it is going to help in difficult cases in prevention of a bile duct injury.
The second question that I have, after going through your both publications, the tube cholecystectomy that you have mentioned. So what is the scenario performing a tube cholecystectomy? I mean, you have nowadays the availability of CT guided drain placement. And if you are taking a patient already to the OR and he is capable of undergoing anesthesia, why do a tube cholecystectomy? Are there anatomical aspects, or are there general condition aspects? What are the indications for this special procedure?
I understand your question. Thank you. The only reason we advocated tube cholecystectomy in a difficult condition intraoperatively is that if the surgeon is not experienced, the anatomy is difficult. So we feel that it is better that he puts in a tube, removes the stone, puts in the tube cholecystectomy, and comes out and refers the patient to an appropriate center so that he can be managed appropriately at a later stage, rather than risking a bile duct injury in that difficult scenario. See, in India, the situation is very difficult. The majority of the places will not have a very good endovision system. They will not have a good assistant. Only one surgeon would be there, and he would be assisted by an untrained staff nurse and an untrained technician. So the conditions are not very conducive. So we recommend that if you get into a difficult situation, there is pus in the gallbladder, or you have opened the gallbladder, better put in that tube, cholecystectomy tube, come out, refer the patient.
Okay.
Virinder, would you like to respond to two comments in the chat? If you can see that. Dr. KJ Singh and Vishal.
Okay. Dr. KJ Singh has asked if we had data showing the incidence of CBD injuries from the hands of surgeons formerly trained in laparoscopic cholecystectomy. I think this data in India is very difficult to get. Who has been formally trained in laparoscopic cholecystectomy is very difficult to define first, and then getting the data whether he has called a bile duct injury, because nobody owns up a bile duct injury in India. So if would be helpful if the guidelines could be made available to all through open. Okay, Dr. Vishal, thanks for that suggestion. Actually, Indian Journal of Surgery, this is an open access article, I think. So anybody can access this article.
So can we have a question?
Only thing I would like to say about the incidents, recently my colleague at SGPGI, Dr. Supriya, and we did a survey of, I think we got about 300 responses, and as many as about 80% of surgeons who responded accepted that they have had at least one bile duct injury.
Okay. I have one more question, and especially not living in India. How are you currently performing lap cholecystectomy? Is it a single day operation, or are the patients staying overnight in the hospital? Because in most European countries, we are now on a very high cost cuttage pressure, and countries like Spain are doing lap calls already on a one-day surgery, a same-day surgery. And this also brings me to the other aspect, that putting a drain or not, because usually you don't see a bile duct injury within the first 24 hours. It may appear after 48, and at that time the patient is already discharged. And how do you ensure that he's followed up properly?
Okay, so to answer your first question, basically at my hospital, we do not follow the policy of same-day discharge of the patient. We will discharge the patient next day, and we will make sure that the patient is all right. He's accepting orally. He's not feeling too much pain. The abdomen is okay. But yes, there are centers where lap cholecystectomy is a daycare procedure, and these are the problems actually precisely why we do not perform a daycare procedure in our institute actually. And majority of the public institutions do not follow the daycare approach for a laparoscopic cholecystectomy, as far as I know. But there are centers which are doing a daycare procedure, and I totally agree with you. The problem of follow-up of these patients, the problem of if they develop complications, who will admit this patient, how will this patient come to the hospital? These are all some issues, logistic issues in India, which I think are not taken care of. So we would prefer to keep the patient in the hospital. In my unit, we would give the telephone number of the junior resident to the patient, so that we tell the patient that if you have any problem, any pain, any fever, you can contact directly this junior resident and come to our ward directly, without going to the emergency or going to the administrative problems. So, but I think this needs a lot of work to be done on this issue. This is a very pertinent issue actually to answer your question.
So you've got
I think we have run out of time.
Yeah.
I can see on the comments. So thank you, Professor Bansal, for this excellent insight. And it was a pleasure meeting you here on this platform.
Thank you.
So do we take a question from the audience or close? We close now.